This case illustrates the surgical management of unilateral left superior semicircular canal dehiscence in a 36-year-old school teacher, presenting mainly with auditory symptoms. She described autophony, the echo of her own voice, an internal resonance that made speaking in class increasingly difficult. Mild imbalance was present, but her main concern was auditory. Pure tone audiometry showed a mild to moderate cochlear conductive hearing loss in the left ear, with an air-bone gap of about 15 decibels between 250 and 1000 hertz. Bone conduction thresholds were preserved. Cervical VEMP testing showed abnormally low thresholds and larger amplitude on the left, indicating third window hypersensitivity. The waveform remained visible even at lower intensity levels, confirming a dehiscence-type response. High-resolution temporal bone CT confirmed a left superior semicircular canal dehiscence. She underwent minimally invasive transmastoid endoscopic plugging, performed with a 30-degree, 2.7 mm diameter, 90 mm otoendoscope. After limited cortical bone removal, the dehiscence was directly visualized. It was sealed with bone pate and fascia, and resurfaced with a cortical bone graft harvested from the mastoid cortex. This reinforced the canal roof and reduced the risk of later encephalocele formation. There was no cerebrospinal fluid leak. The transmastoid approach is preferred when anatomy is favorable, providing direct access with minimal bone removal and avoiding a craniotomy. By contrast, larger defects, or those with encephaloceles or more medial positions, are best treated through a small middle fossa subtemporal approach. Compared with the middle fossa route, the transmastoid technique offers lower morbidity, smaller exposure, and excellent visualization for precise canal occlusion. This case demonstrates that when anatomy is favorable, the transmastoid endoscopic approach provides a safe, minimally invasive, and effective solution for superior canal dehiscence, achieving complete symptom resolution while avoiding the need for craniotomy. Auditory symptoms resolved immediately after surgery, including autophony and echo. She experienced only mild transient imbalance, and physical therapy confirmed that she could walk independently and manage self-care. She was discharged on post-operative day 2 and returned to work at 1 month. By 3 months, hearing and balance had fully normalized, and she resumed normal daily life without residual symptoms.
Here I am performing a transmastoid minimally invasive approach to repair the superior semicircular canal dehiscence. I perform a simple mastoidectomy initially, but preserve the lateral bone plate. Now I am harvesting some bone paste that will be used for the repair. The bone plate is removed and then sculpted because we are going to enter the space between the dura and the superior semicircular canal. At this point, I'm completing the mastoidectomy, and now I am exposing the space between the superior semicircular canal, and you can see the overlying dura that's been exposed. I gently elevate, not to violate the lumen of the superior semicircular canal that is dehiscent and contains the important structures of the inner ear. Now I use a 30-degree angled endoscope to assist in viewing where the defect is. The defect is not visible transmastoid without the use of the endoscope in this case. Here you can see the lumen and the opening of the superior semicircular canal and the beating pulsations of the dura of the middle cranial fossa. I am repairing the canal with a combination of soft tissue and bone pate. I am placing the bone pate into the lumen very gently to compress it. This portion is done under operative microscopy because using the endoscope I have clearly defined the limits of the defect. Now I have fashioned a bone plate to repair the defect in the bone so that the patient does not experience an encephalocele in the future from the area of bone that was removed to access the superior semicircular canal. A small guide hole is drilled so that I can handle and push the bone plate properly sized into position gently and elevate it above the repair to not disrupt this region. Once this is completed, I add additional bone pate to help prevent and seal up the defect that was created to access the canal, and then cover it with absorbable gelatin material for proper healing to hold the repair in place.